Each disorder caused by a deficit of activity of a specific enzyme required for catabolism of glycosaminoglycans. This leads to storage of glycosaminoglycans within lysosomes, cells, and outside the cells. Dermatan sulfate storage is connected with connective tissue damage. And heparan sulfate is connected with central nervous system damage. And when we have a situation when dermatan sulfate and heparan sulfate are stored together, so we will have MPS 1, 2, and 7, and neuronopathic form, these three MPSs with neuronopathic subphenotype. It was challenging to say what is the earliest or early signs common in MPS 1, 2, and 3. These 5 points I found are observed in all neuronopathic forms. To be honest, not only in MPSs, but this is a cognitive impairment, attention deficit, increased activity, and sleep disturbances, and behavioral difficulties. Of course, there are some differences at age of onset among type 1, 2, and 3 between the severe and attenuated forms. I would like to focus more on behavioral disturbance. How it is in MPS 2? It means that if you see in MPS 2 patient, earliest you see neurological or behavioral problems in a patient with MPS 2, you can be sure that it will be more severe form of MPS 2. This is interesting data done by Holt. He measured 6 parameters in MPS 2 patient, like cognitive development, adaptive behavior, receptive language, expressive language, gross motor, and fine motor. Looking at a glance, you can see that for all these parameters around the age 3 and 5, there is an evident decline of their development. From host data, we can say that cognitive disturbance is noted quite early at the age of 2 or age of 3. And hyperactivity is on the second place, looking on this ranking, and could be observed quite early around the first year of life. Another problems which can interfere the normal development and normal behavior. It is communicated hydrocephalus, common in MPS 1, 2, 3, and 6. It's could be associated with increased intracranial pressure and may contribute to cognitive deterioration or behavioral changes like headache, vision disturbances, or others. But this is slowly progressing, and this is now the main aspect influencing the behavioral aspect. Here there is a very nice and very informative picture from Manara publication. This is atrophy, communicating hydrocephalus, and marked CSF space in subarachnoid space, in ventricular, and in both. And another from the same author, similar, very nice set of pictures showing the development of hydrocephalus and cerebrospinal fluid subarachnoidal in one girl with type 2, done at the 5, 6, 7, 8, 9, and 10 years. You can see the progressing changes in central nervous system. This was mentioned before about the spinal cord compression. This is the sign or symptom we can meet in MPS 1, 2, 4, and 6. And you can see on this picture that there is a narrowing of the space, especially at the atlantoaxial joints, with all consequences in the clinical picture. The earliest complaints of patients with upper cervical compression include loss of endurance and diminished walking distance, some gait instability, but it's also the very slowly developed symptoms, expressed more severe in lower extremities. But also you can observe the other symptoms, neurological, like superficial sensor loss, muscle weakness, clumsiness, and so on. But these symptoms progress also quite slowly. Hearing loss is also quite a common problem. Still, we don't know what is the main. If it is purely sensorineural hearing loss or conductive. We don't know which part is the most important, but I think that it could depend on the type of the disease and the given patient. Italian studies showed that 75% of all these MPSs together present hearing loss. And from host data in MPS II, we can see that there is 67% of all patients present the hearing loss, which is important, of course, in their cognitive development and in general social and everyday functioning. Carpal tunnel syndrome is also quite often in severe form of MPSs 1, 2, and 6, where dermatan sulfate storage plays its important role. Seizures. I would like to emphasize that seizures are not the earliest symptom in MPS. Why I put this information? To emphasize that it is not the earliest or early symptom in MPSs. Seizures are common in older patients with MPS III, with MPS II, but in more advanced stage of the disease. Summary is that you know very well that neurologic complications are common in MPSs. The participation of pediatric neurologists who must be involved in this set of characteristic symptoms, neurological symptoms in MPSs, is absolutely necessary.